So, good afternoon or good evening, everybody. I thank Dr. Subhashini and AOS for giving me this opportunity. So, when you are afraid of hypertony, when you are afraid of failure of bleb, then you have to think about spacing devices. So, what are these spacing devices? These spacing devices are the ones which are placed under the conjunctiva over the scleral flap to maintain that space so that it maintains that space, prevents fibrosis, and then it also prevents hypertony or overfiltration. So there were a few spacing devices. 10 years back, when there was a surgical glaucoma international conference, there was a Heloflow, which was a gel which is placed subconjunctivally, but that didn't take up well and it didn't come to the market, hit the market profusely in India. So the one other thing which had a very good impact in our glaucoma surgery is the Ologen. So what is Ologen? Ologen is nothing but artificial porcine extracellular matrix with 90% nut-low collagen and 10% glycosaminoglycans, which is 95% porous with 10 to 300 micron size, comes in a sterile ready to implant pack. So it comes in various sizes. We generally use 6 mm into 2 mm cylindrical Ologen, or a rectangular 12 mm into 1 mm. So what are the indications for any spacing devices? Previously, considering cost, we have been using it specifically for requirements where tendency for bleb failure is high. Now we started using with primary trap too. So primary trap, repeat traps when previous trap has failed. When you suspect thin sclera and conjunctiva where you cannot use a mitomycin C, then you can use Ologen. And when you expect higher failure rate, like inflammation associated with glaucoma, younger glaucoma patients, and when you have other eye with lot of cystic blebs, MMC associated complications, then you can think about Ologen. So extended indications apart from normal literature driven, so it can be one eye to be on the safer side in pregnant glaucoma patients. When you expect post-operative bleb leaks, when other eye had the leak, then even you can use it in bleb revisions. Bleb in non-superior areas, in VIP patients where you cannot afford a complication, and in case of an outpatient or daycare surgery and a single person glaucoma department where you cannot closely monitor all those patients, safe to use an Ologen. So how does it work? Task 1, since it's a cylindrical implant, it produces a pressure on the scleral flap, and when the Ologen gets dry, it becomes softer, it becomes lighter, so that it allows the flap to come up, drains the aqueous. When it gets soaked, it becomes heavier, then it puts a tamponade effect on the scleral flap, controlling the flow of aqueous from the anterior chamber. So thereby it prevents hypertony. Task 2 is it allows the myofibroblast to grow through those pores which I said earlier, like 10 to 300 micron pores, so that it prevents the ring of steel. The myofibroblast are not restricted to the edge of the bleb. It is allowed to grow in through the porous, so it prevents ring of steel formation. Task 3 is loose connective tissue matrix reduces scar formation, and it acts as a spacer subconjunctivally until 180 days before it gets spontaneously dissolved. So this is the video. So what are the precautions you should take? You should undermine the conjunctiva and tenons very well. It should be bigger than 6 mm all around, so that because the cylindrical Ologen is 6 mm into 2 mm, so it should go comfortably set. It should not be restricted. If you have a smaller space and if you try to push it in, then the chances of extrusion or protrusion are much higher. Then ideally a releasable suture, you can see here a releasable suture has been put here. So because since it's a 2 mm Ologen, you cannot visualize the suture when it is interrupted. So there is chances of you doing a suture lysis is much lesser. It's much difficult. So you ideally put a releasable suture. If you are planning an interrupted, then go for a 12 into 1 mm Ologen, where the 1 mm Ologen at least allows a partial visualization of the interrupted sutures. And as people do even use Ologen, cylindrical Ologen, cut into 2 and place on either side of the flap, so that the central interrupted suture is visible for them. Ideally, subconjunctivally it is placed. People started using sub-flap or subscleral, but there were complications associated with placing the ologen under the flap. So I use it only under subconjunctivally. So problems with spacing devices, it gives a false sense of raised or functional bleb. You should be aware of it. So look for microcystic changes on the edge of the bleb near the limbus, and also when you give a digital massage, look for the flow on either side of the bleb, so that whether the aqueous is bulging out on either side of the ologen. And so difficult to check the flow, so you have to look at the edge, not at the center of the flap area. And when you have complications or when you want to repair the bleb, it's quite difficult when you have an ologen. Then there was a recent study in Canadian Journal of Ophthalmology published in December 2019. Ologen was immortal for last 10 years. This 33-year-old patient who's a juvenile onset primary open angle glaucoma patient had trapped with ologen in 2008, presented with high pressure and glaucoma progression in 2018, and you could see the ologen remains exactly of the same size what it was implanted of even after 10 years. The author suggests that they have soaked ologen with mitomycin and have implanted it. So probably mitomycin has probably impaired the vasculature and all those things, and it prevented the spontaneous absorption of ologen. So use one other take home message is, when you are using ologen, use ologen alone, don't go soak with MMC. So ideally it should not be done. And complication is, can, as I said, if you don't undermine it properly, it can extrude or protrude. Conjunctival erosions can happen very rarely. Folding of implants when you don't undermine it properly, and it really forms a awkward bump on the bleb area. And when you keep sub flap, if you cut a piece of ologen and place it under the flap, it can protrude into the ostium and block the ostium. You could see a gonioscopy showing an ologen here blocking the ostium. So it is a real problem there. So complications, various studies I have gone through, and ologen produces only one commonest complication is early hypotony. That is less intraocular pressure within 7 days of implantation, within 7 days of trabeculectomy, because probably we are putting one apical suture or one apical releasable suture, that too of slightly on the looser side, less tighter side. So it might cause overfiltration and can cause early hypotony, but it didn't persist for long. It settled within 7 days. Lot of studies showed lot of early hypotony, but not much of late hypotony. So one other problem is the cost. Is cost a problem? 10 years back, probably even in our patients, suggesting a ologen for 8,000 or 10,000 to a patient is costlier. Now I feel it's not much, because it is only 11 months of Trevetin, 12 months of Lumigan, and 13 months of Zelatin. So it's somebody who uses these prostaglandin analogs for quite some time. It is not much. What is only 1 year of prostaglandin analog, so you can better use it. Problems are very less, but benefits are more. Thank you.